first speaker is Dr. Ahmed Khalafallah. Dr. Khalafallah received his medical degree from the University of Sharjah, United Arab Emirates, and completed his neurology residency last year at Houston Methodist Hospital. He is currently a vascular neurology fellow at Houston Methodist. His clinical interests include acute stroke management and stroke recovery. Thank you.
Okay. Thank you, Amber. Good morning, everyone. I'd like to start my talk today with what Henry Rollins once said, that change is hard, but change is good. And I'm not sure if you would agree with that, but for me personally, I feel that I can manage the difficulty that comes with any change in my life, but only when I feel the change is necessary, important, or even promising. And hopefully before the end of my brief presentation today, I can show you why I feel that it's time to change from Tenecteplase to Tenecteplase for the management of acute ischemic stroke patients. To understand the pharmacological difference between the two agents, let's go briefly over the physiology of fibrinolysis. And we studied that in the medical school, and we know that once a fibrin blood clot is formed and the injured tissue has been repaired, it's time actually to limit the spread of the blood clot through initiating of fibrinolysis. And this occurs through the attraction of plasminogen here and the tissue plasminogen activator to the fibrin clot. And tissue plasminogen activator is a protease enzyme that catalyzes the conversion of plasminogen to plasmin, converting the fibrin into fibrin degradation products, limiting the spread of blood clot. And to maintain homeostasis within the system, there are several factors counteracting those agents. We have the plasminogen activator inhibitor, type 1 activity, inactivating tissue plasminogen activator, and then the alpha-2 antiplasmin, and definitely the coagulation factor 13 as well. So Tenecteplase, it's derived from the native TPA by modification at only 3 amino acids within the primary protein structure. And the 1-letter code for the amino acids are T and K, and that's why the name is T and K. And because of the modification within the primary protein structure, Tenecteplase is different pharmacologically from Alteplase. And we know that Tenecteplase is at least 14 folds, having like high fibrin specificity, limiting the effect of the drug to the action of the fibrin itself, minimizing the systemic side effects. Also, Tenecteplase has at least 80 folds increased in the resistance to the plasminogen activator inhibitor, and this could explain the difference in the clearance and the half-life of the medication. Tenecteplase has a half-life of 20 to 24 minutes. For Alteplase, it's only 4 to 6 minutes. And because of the difference in the clearance and the plasma half-life, Tenecteplase can achieve thrombolytic effect through like 1-dose injection. There is no need for infusion, the 1-hour infusion that we do with Alteplase. The Tenecteplase, it's not a new drug. It has been studied for over 20 years for MI patients, and it was approved by FDA for management of acute MI patients in early 2000. And the dose that is being used for MI patient is 0.5 milligram per kilogram, and the standard dose now for stroke patients is 0.25 milligram per kilogram. And Tenecteplase is a lot cheaper than Alteplase. And this is from last year. For 100 milligram vial of Alteplase, it's around $900 to $200. And for Tenecteplase, actually the prices here are the opposite. So for Alteplase, for 100 milligram vial, it's $80 to $200. And for Tenecteplase, for the 50 milligram vial of Tenecteplase, it's nearly $60 to $100. And it's not clear if the company Genentech is willing to produce the 25 milligram dose for stroke patients, which will be a lot cheaper than that, with huge price difference between Alteplase and Tenecteplase. Now moving to the clinical evidence beyond the Tenecteplase, the first meta-analysis here was conducted in 2019 to compare Alteplase at the standard dose of 0.9 to 3 different doses of Tenecteplase, 0.1, 0.25, and 0.4 milligram per kilogram. And they included 5 major head-to-head trials. The first one here, the TNK-S2B trial from US, and then the TACE study from Australia, a TAST from Scotland, and NORTEST, the biggest, and it was the only phase 3 trial in this meta-analysis. It came from Norway, and then the most important trial, the EXTEND TNK trial. This meta-analysis included around 1,600 patients. Nearly 800 patients received Tenecteplase, and 800 patients received 3 different doses of Tenecteplase. And if you look carefully here at the median stroke scale, it was nearly 14 for the majority of the trials, except the NORTEST trial, which included patients with minor ischemic stroke with median stroke scale of 5.7. And the time window again for the latest 3 trials, the time window was less than 4.5 hours, which is the current standard. And except for the American trial, the earliest trial, which was less than 3 hours, and then the Australian TNK trial was less than 6 hours, and they had selective imaging criteria for enrollment. To look at the primary efficacy endpoint, it was freedom from disability, and they defined it as MRS score of 0 to 1. And if you can see here at the total events number of the primary outcome, so the percentage was nearly 58% for the Tenecteplase group compared to 55% for Alteplase group, with a risk difference of 4%, as you can see here, and a confidence interval of -1 to 8. And the -1 of the confidence interval fell within the non-inferiority margin that was established by the investigators. And the results were somehow favoring Tenecteplase. And there was no effect of modification according to the dose of Tenecteplase. They didn't find significant difference in the efficacy between the 0.25 and 0.4 milligram per kilogram dose. And similar results actually were found for the remaining efficacy endpoints, including functional improvement and then the degree of disability at 3 months after stroke. Looking at the safety endpoint with the symptomatic ICH, again, the crude rate of symptomatic ICH was 2.8% for the Tenecteplase group and 2.6% for the Alteplase group, with a risk difference of 0. And this was not statistically significant. Again, the conclusion from this meta-analysis mainly that Tenecteplase was at least non-inferior to Alteplase for management of stroke patients, and because of the bulk of the patients came from the NORTEST study, NORTEST 1, and the median stroke scale for this trial was 5.7, so the majority were actually having ischemic stroke symptoms in the mild to moderate severity, and that's why, and this was the only trial that studied the 0.4, the higher dose of Tenecteplase. And that's why the 2019 American Stroke Guidelines actually recommended the use of 0.4 milligram per kilogram dose of Tenecteplase for only patients who are coming with minor stroke presentation based on the results of the NORTEST trial, because post hoc analysis for the patients in the NORTEST trial, they found that the patients with severe stroke presentation who received Tenecteplase at 0.4 milligram dose, they had higher symptomatic ICH and higher rate of mortality. And this was actually confirmed in the NORTEST trial, the NORTEST 2 from last year. It was terminated early because of the concern of symptomatic ICH and mortality with the higher dose of the 0.4. And I believe that the recommendations will change regarding the dose of Tenecteplase. And then to switching gear now for the use of Tenecteplase for large vessel occlusion. And this meta-analysis was published in 2021, and it included patients from four major head-to-head trials. And the most important trial, as we discussed, the EXTEND TNK trial. And this was mainly comparing Alteplase to Tenecteplase, mainly at 0.25 milligram dose for patients presenting with large vessel occlusion. And the primary efficacy endpoint was functional improvement with MRS score of 0 to 2. And what they found that the odds of achieving the favorable functional outcome was 2, with a statistically significant difference here as you look at the confidence interval. They also looked at the rate of successful recanalization after mechanical thrombectomy, and they found that the odds of achieving successful recanalization was much higher in the Tenecteplase group, with odds ratio of 3 and statistically significant confidence interval. Also, the functional improvement was also favoring Tenecteplase group compared to the Alteplase group. The rest of the primary efficacy endpoints and the safety and symptomatic ICH, there was no statistical significant difference between the two groups. And this is a graphical representation of the Tenecteplase again effect on the functional improvement and the successful recanalization and the MRS of 0 to 2, and they were all favoring Tenecteplase, as you can see here in this graphic representation. And that's why, and based mainly on the results, as you can see here, of the Extend TNK trial from Australia and New Zealand, the American Stroke Guidelines in 2019, they are recommending now Tenecteplase at a dose of 0.25 milligram over Alteplase. So it's even more superior to the standard dose of Alteplase for patients coming with large vessel occlusion and eligible for thrombolytic treatment. So now the guidelines have two different doses, 0.25 mainly for large vessel occlusion and 0.4 for minor stroke presentation. But it's not only the American Stroke Guidelines. The Tenecteplase has been discussed in the major stroke guidelines, mainly with the Australian Stroke Guidelines in 2019. They are now recommending Tenecteplase over Alteplase for ELVO, and they are giving the Tenecteplase as an alternative recommendations for non-ELVO patients. And this is similar to the American Stroke Guidelines. The European Stroke Guidelines in 2018 recommended against the routine use of Tenecteplase in clinical practice. However, in 2019, they released an update saying that 7 out of 11 stroke experts recommending now Tenecteplase over Alteplase for ELVO patients. The Canadian Stroke Guidelines did not discuss Tenecteplase in their guidelines in 2018. However, last year in the European Stroke Conference, the ACT trial in 2022, they released their final results about the use of Tenecteplase in stroke patients, and they found that Tenecteplase at a dose of 0.25 was definitely non-inferior and somehow was superior in some of the functional outcomes to the standard dose of Alteplase. And that's why in September of last year, the Canadian Stroke Guidelines released an update stating that Tenecteplase now can be used as an alternative to Alteplase for stroke patients. And there are multiple ongoing clinical trials. We are still waiting for the final results. TASTE-A trial from Australia, they actually released their results last year about the use of Tenecteplase in mobile stroke unit in Australia, and they found also that Tenecteplase was even superior to Alteplase for stroke patients. Tenecteplase also is being studied now for the extended window period between the 4.5 hours to 24 hours for patients coming with large vessel occlusion in the Timeless study here in the US. And they are using the same imaging criteria as diffuse trial. And we are still waiting for the results. I think the completion time will be 2025, so still we have time. And also we are still waiting for the final results from the Chinese trial of using the Tenecteplase in the extended window for large vessel occlusion. So this report was published last year about the New Zealand Regional Stroke Network. They published the report about the transitioning process from Alteplase to Tenecteplase. And they did the transition in February of 2020. And then in this report, they included nearly 800 patients, 555 before the transitioning process, and then 300 after they transitioned to Tenecteplase. And what they found in their analysis that the patients treated with Tenecteplase, they had better MRS on the dichotomous and the shift analysis curve, and also they had fewer incidence of symptomatic ICH and even 7-day mortality. However, this was not statistically significant. The median door-to-needle time also was better for the Tenecteplase group in their analysis. So what I'm selling you today, the idea of a drug which is cheaper than Alteplase, that has better pharmacological properties, that can be given as a single bolus injection, no need for infusion, much easier for the patient, much easier for the hospital staff and our nursing staff, more convenient for inter-hospital transfer, more convenient for the mobile stroke unit. and definitely non-inferior to alteplase for non-elbow patients, and it's showing superiority to alteplase for elbow patients. Drug now has been endorsed by the major stroke guidelines all around, and it has been in the clinical practice here in the US for over 2 years now for management of acute stroke patients. So I know that it's not easy to switch, especially in a big system like Methodist with the ongoing trials, but I still believe that our patients deserve at least to initiate the discussion of transitioning to Tenecteplase. And this is the references, and yeah, thank you so much.